When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. A rainbow is a division of white light into many beautiful colors. These take the shape of a long grand arc with its path high above and its end way beyond the horizon. There is, according to legend, a boiling pot of gold at one end. People look, but no one ever finds it. When a man is looking for something beyond his reach, his friends say he's looking for the pot of gold at the end of the rainbow.
Welcome to the Joy Tuck Club, the podcast that celebrates the beauty and diversity of transgender individuals and identities. I'm Rachel, my pronouns are she, her, and with me is my wife and freshly fringed co-host, the beautiful Phoebe. What are we doing today, Phoebes?
We're clearing our pipes, tuning our mics, and trying not to sound like a pair of squeaky door hinges as we tackle all things related to gender-affirming voice surgery, also called vocal surgery, also called voice feminization surgery, and there's a bunch of other terms, but it all means the same thing, taking a scalpel to the voice box.
Now that sounds like a lot to swallow.
It is, but you know what? We also talk with someone who knows how voices work. His life-completing surgeries have helped countless patients reclaim their confidence through vocal feminization.
But before we play that interview, can we talk a little bit about the Facial Team Gender Affirming Healthcare Forum in London? We were lucky enough to be invited to speak at a few weeks ago.
We really were. Thanks, Facial Team. So the forum had a bunch of world-class surgeons and therapists from all walks of gender-affirming care. It was actually pretty fabulous.
And quite intimidating to be amongst such gods in the trans healthcare world.
I know, there's little old us.
Little old us, yeah.
Where they're presenting, we gave a talk about the current crisis in healthcare in the UK and the need for allyship from the medical community to overcome the blocks in prescriptions, the increasing number of people doing DIY, etc. And that even just ordering a blood test for us can make a huge difference. But meanwhile, you have all these people who, oh my God, we're going to be interviewing all of them in this.
I know, we were so lucky to have access to these people.
Right?
And they're all lovely as well.
They are. And these are people who have performed more procedures of these types than pretty much anyone else in the world. They've developed new techniques, sometimes new equipment to perform these types of procedures. And it includes facial surgeries, top surgeries, and actually there wasn't anyone specializing in bottom surgery there, but there were the connections.
Yeah.
So, yeah. So why are we doing all these interviews?
I don't know why. For the book.
Well, for the book, thank you.
For the book.
How to transition.
How to transition.
Yeah. Which is how this podcast started, of course, because we were interviewing people and wanted to record them to get the transcriptions. And then it seemed fairly obvious to make something more of that. But it was all for the book.
So we've got a very busy couple of weeks coming up.
We have.
We've already done 3 interviews. Yeah, and this is the first one we're actually putting to the mic.
Yes, it is. But I wanted to mention something. You know the passage that opened up this podcast?
The Rainbow Passage.
The Rainbow Passage.
Which is not a euphemism. You could have the Rainbow Passage and the Rainbow Bridge. But it's not a euphemism.
No. The Rainbow Passage. So I did some diving.
Yeah, well, I first became aware of this at the forum. I'd never heard it before.
Yeah.
Do you want to tell us exactly what it is?
Yes. Well, and it's also a passage that people will hear when they go to the websites of these surgeons. Often it's the standard recitation used to show before and after results.
But why that passage?
Why that passage? Okay, so I love this part. It was developed by engineers or technicians or whoever they were at Bell Laboratories back before the 1920s. Like we're talking about the telephone and they're testing speakers. And
Wait, Bell as in Alexander Graham?
Yes, that bell. Yeah, rings a bell, huh?
Rings a bell, yeah.
And they were testing early equipment. And one of the marks of quality in that equipment was ensuring it could pick up every type of pronunciation we make. They were using English. And so this passage was developed that contains all the phonemes and so forth, essentially all the sounds we make, in its first 4 lines alone. And that is now used in all sorts of voice therapy.
Yeah.
Not just for gender-affirming care, but also for rehabilitation, for training for acting as well, for learning to switch accents and so forth. It's quite fabulous.
Yeah, it is.
And so we got the surgeon to read it.
Yeah.
Chadwan, who's wonderful. You'll meet him.
Yeah, that kind of came out of left field, didn't it? He didn't. I don't think he was expecting that.
No. Like, what? Wait, what?
But he performed admirably, though.
He did.
Yeah.
Yeah.
Of course, as you'd expect.
Yeah.
So let's talk a little bit about gender-affirming voice surgery.
Yes. So, and you'll hear a lot of the detail here in the interview, but
This is like a bite-sized revision guide for you without having to listen to the full thing. We're just going to go over the highlights.
the cheat sheet.
The cheat sheet.
Yeah. So it's a very quick procedure. It takes about 2 hours from administering of the anesthetic. It's done under a general. There's no need to stop hormones. There's no impact. But if you smoke, you need to stop.
As you should with most, all of the surgeries. Even if you're not having surgery, you should stop smoking.
Yeah. Normally that's because it impacts recovery time.
Yeah.
In this case, it reduces the need to cough because after the surgery, your vocal cords are stitched together in certain places and they're healing. They may have been quickly scarred with a laser, which has the effect of knocking the lower ones out of action, which is what we want. But you can't put any stress on them. So you can't speak for quite some time. And you certainly want to avoid anything like coughing.
Yeah.
Now, one of the questions we asked was how long you should wait after transitioning to do this surgery, because as we've learned, you need to wait a certain amount of time before top surgery.
Yeah.
For example, if you're trans femme, because you want the hormones to do what they can as much as they can. And in this case, it can essentially be done at any time.
Is that because estrogen doesn't actually affect the vocal cords?
Yeah, if you're...
Yeah, so there's no point waiting because nothing else is going to happen.
There's nothing to wait for, yeah.
But how about trans masks?
Yes, testosterone does, yeah.
And how long should they wait?
About 6 months, I think was the answer, yeah. There's no overnight stays. It's a day surgery.
It's a quick surgery.
Yeah, in and out. Although, as we've learned, they can also do that with breast augmentations. And what about the possible issues with the surgery afterwards?
Yeah, this is what I found probably most interesting to come out of this interview. Because I'm someone that's not happy with my voice and considering this kind of surgery. As he spoke about the loss of pressure and range you can get from this surgery.
Yeah.
There are different types of surgery, and the most popular one, the glottoplasty.
Yeah.
They don't recommend it, probably for someone like me.
Yeah. Oh, the Wendler's.
The Wendler's glottoplasty.
Yeah.
They recommend it. I'm a perfect candidate not to have it because I work in the noisy environment.
Right.
So I need to have a loud voice to be heard. And also, I'm not a great singer, but I do like to sing. And
I think you're awesome.
I've got a lot of character voices that I do for all of our daughters' toys. And I just don't think I would be able to wrangle my voice to do all of the stuff that I do after I've had this because it restricts your range and you lose pressure. Sound
pressure meaning the loudness. So you're going to have trouble making yourself overheard in noisy situations. Yeah.
But that doesn't mean that I can't have surgery. There are other types.
Yes.
That I could have, as we'll cover in the interview.
Right. Muscle fold reduction is one of them. It may not have as effective an increase in feminization, but it does retain some other characteristics that you need. As for me, I'd love the surgery right away, but I'm not going to.
You're not going to?
Needs to be planned to fit in with other things.
Yeah.
Yeah. Mm-hmm. Yeah.
Yeah, we'll talk about that another day.
Yeah, we will. So something to know when you go shopping around for this type of surgery is there actually aren't that many in the world. I think it was about 24 in all. And they do offer different sorts of specializations, but if you're wondering which technique might be the best, it's the one that the surgeon has favored because they're most comfortable with it. And it's a very delicate little operation.
They all tend to be variations on a theme, though, don't they?
They do, yeah. Yeah. The one that is more extreme, all of these are closed surgeries, so they're laparoscopic or keyhole. They go in through the throat. But there is one surgeon in California who does an open surgery. It's needed for dealing with other types of complications, so he goes in through the larynx. And I think perhaps one other thing that should be highlighted is, in this case, this type of surgery, it is very delicate and very specialized. And you don't want just any sort of surgeon jumping in there. And it's easy to be led by the promise of cheaper prices from medical tourism. But very much don't do it. Your voice, if that's how you primarily communicate with the world, is not something you want to put at too much risk.
Yeah, absolutely. And I think that's kind of the camp I'm in at the moment.
Yeah.
Much as I hate having to talk on the telephone and probably quite mute in a lot of public situations.
Yeah.
I have to weigh up that versus everything I could potentially not have anymore.
Right. Well, I just want to add on your singing that one of my first memories after we met, I was returning from Thailand. You picked me up from the air. No. We're driving down to Brighton.
We're going to Brighton.
And you serenaded me.
Oh, you're welcome.
Yeah. From Moana. And first time anyone's ever done that. And that's your superpower. So I wouldn't like you to lose it. But you need to do what you need to do.
Maybe a bit of vocal training, which goes hand in hand with this, by the way.
It does. It does. And that's another of the interviews we're doing shortly. Yeah.
But I think that's enough from us.
It is, yes.
Let's take a trip back through the mists of time.
Cue the harp. And now let's introduce our special guest, Dr. Chadwan Yaghchi, a surgeon who helps trans folks hit the perfect note.
We met at Facial Team's Gender Affirming Healthcare Forum, where he gave a fascinating presentation on gender affirming voice surgery, including some quite detailed research.
Dr. Yaghchi is a consultant laryngologist, ear, nose and throat surgeon at the London Voice and Swallowing Clinic, and also has an NHS practice at the National Centre for Airway Reconstruction and Imperial College's Voice and Swallowing Centre, based at Charing Cross Hospital.
He's also the treasurer of the International Association of Trans Voice Surgeons, where he leads global efforts to advance transgender voice care, and is an accomplished researcher with a PhD in molecular oncology, focused on groundbreaking cancer treatments.
Dr. Yaghchi has held leadership roles in prestigious organisations like the British Laryngological Association and the Royal Society of Medicine.
But he's perhaps best known for his revolutionising voice feminisation surgery. He's introduced his own modification of the Wendler glottoplasty to the UK, and it has since become the gold standard of transgender women seeking to align their voices with their identities.
So tighten your cords, reduce your fold, clear your throat, and let's welcome Dr. Chadwan Yaghchi to this pitch-perfect, we hope, conversation.
Welcome to the Joy Tuck Club, Chadwan, and thank you for taking the time to talk with us. We're not even sure how you managed it, given how busy you are. What do you usually do when you have a little spare time?
Thank you very much for having me. I feel, honored and for the very, very kind introduction. So, when I have a little bit of free time, I like cooking. So, outside medicine and all of that you mentioned, I'm fairly good cook, and that's what I enjoy doing in the evening most. However, tonight I'm on call for my NHS job, so I am on call, waiting to hear if there is something happening. I'm a consultant ENT surgeon, so I'm mainly, although my training is ENT, my focus, I'm a laryngologist, so I do just the T part of ENT. So I just manage throat condition, and in particular on the NHS, I manage a lot of people with airway stenosis, which is narrowing of the windpipe, so it causes difficulty breathing. So we widen that either by endoscopic or open reconstruction technique. And then the other part, my 50%, the rest of my time is I'm in private practice. So I do, again, purely laryngology. So I do manage only throat problem and in particular transgender voice.
So, why do transgender people seek voice affirming surgery?
Voice is an essential part of our identity. It's essential part of who we are. I was speaking a while ago in the British Voice Association, and the title of the seminar was "We Are Our Voices," which is true. Like voice is an integral part of our identity, and when your voice does not align with your gender, then it becomes difficult. You need to try to align your voice to your gender, and then you will have various different ways. So you can do therapy, you can do self-training, but that may not work for everyone. And some people would like to explore the surgical option. And the surgery offers you a layer of security as well, because with voice, with training, it's a conscious effort, while surgery can take that conscious effort away for the right person.
Does the NHS also support this surgery?
Unfortunately, no. So that has stopped because transgender health and all of the gender dysphoria pathway within England is managed, commissioned centrally from NHS England. So what's currently, so in 2019, the guideline has changed and a lot of surgeries were no longer funded on the NHS, including gender affirming vocal surgery. So what's left is SRS and top surgery for trans men, pretty much in terms of surgical intervention. Facial feminization, breast augmentation, and voice surgery is no longer funded.
Right. Are you aware, are there any private insurers that will fund it instead?
Yes, in fact, most insurers do at this minute of time, but purely all to everything that come my way is for business insurance. So people for who have insurance via their workplace, and the workplace need to request that particularly, and then they will have that agreement with the insurer. But from personal insurance, I don't think it is available to the best of my knowledge, not as yet, but hopefully in the future.
A patient in one of your case studies said a big part of the process for me was letting go of the techniques I had learned through voice therapy, which had become a bit of a safety blanket. How closely do you work with speech therapists to prepare patients for surgery and enhance results post-surgery?
It's a true partnership. I can't do what I do without the support of my fantastic speech and language therapy colleagues. They do all the heavy lifting, to be honest. I do a little bit, and then they manage the whole process. So I think in general, you will have two approaches. So you either go with voice therapy as your primary intervention, and then you will have the therapy, you will have the feminization therapy, you look into pitch elevation, resonance, speech pattern, intonation, all of that. And if that it doesn't work, then, or it doesn't work to where you want it to, you can look into surgery as an alternative. So that's one way. The alternative way is to do surgery as your primary intervention with the support of therapy to complement what the surgery can achieve. And that's essential part of this process, because if you just do the operation, one, it's like any other surgery. You need rehabilitation after. And for us, the voice therapy, they provide this physiotherapy for the throat. So you need to learn, once your vocal cord has been adjusted surgically, you need to learn how to use them correctly, how not to overuse your voice, especially in the early period, how to restore some of the functions that you might lose because of the surgery, how to get your projection right, etc. So there is a great deal of preparing the patient before surgery and then some rehabilitation sessions after surgery. And once the voice settled and the person who went through surgery can use their voice comfortably, then it depends on that point if their voice now aligns with their gender expression and expectation from their voice. And if it's not, they can look into further therapy to address the areas that surgery does not address, particularly resonance and speaking pattern.
So do you think voice therapy before having the surgery is advisable?
The jury's out on this. So, as you mentioned, there is a lot of research. I'm a man of science, and I really like my research and looking into actual research. We don't know from research finding what's the answer to that question. Almost everything is published is a combination of surgery and therapy. There is nothing that's comparing the two directly like for like in a trial way, like a well-controlled trial. So to see if you do surgery with no therapy whatsoever, are your outcome different to having therapy before? So the answer is we do not know. I think there is a great benefit to it. I'm not too sure if you need a full course of therapy before you proceed for surgery. Like the old thinking, especially when we had limited techniques, that the results were not great, that surgery is reserved for failed therapy. I don't think that's true anymore. I think it's perfectly valid to do either therapy or surgery, then therapy as required. And that's an individual choice, an individual discussion between therapist, surgeon, and a patient.
Thank you so much. We want to talk about the consultation process because I think that's something where there's a lot of questions, and how best patients should approach the consult, how they should prepare for it. So to begin, how long are your consults, and what questions do you wish a patient asks during that time to make the best use of them?
So our consultation is normally half an hour, face-to-face consultation. So we'll take short history, normally first 5 minutes. Then we do our examination. So I do endoscopic examination to examine the voice box, looking at the vocal cords, make sure everything is healthy. Vast majority will be healthy, and it's a normal healthy larynx. It just the voice does not align with gender, but there is no condition that needs managed in the vast majority of cases. And then we do pitch measurement. So we look into what's our baseline, reading and speaking. And then based on what we find, we will move into the discussion and we talk step by step on surgery. What do we do? What are the options? And then we moved into what are the voice outcome, potential voice outcome, failures, complication, voice trade-offs, all of that. So we try to cover all aspects of what a person might face. What we try to do when we are first contacted, when somebody contacts us either directly to my secretary or via our website when they put an inquiry, we try to send a detailed information. And we have like a good 30 pages booklet we send beforehand that will include a lot of frequently asked questions. So, and we encourage everyone to read through it. I know it sounds like a lot, but this is like an operation you want to do once, and it's a life-changing event. So take your time, don't rush, read through what we send, look into examples that are on my website, but also look at independent examples that people who had surgery with myself, they put their results either on YouTube, TikTok, social media, or on Reddit in particular. Read on patient experiences and what did they face, especially in the post-operative recovery period, and prepare some question. I think we do a detailed discussion in the consultation, and I try to cover all aspects, but I can't cover every single question. So when a person comes to see me, have a list of questions will be very helpful for your understanding and for mine as well.
Do you find that patients often have a unrealistic expectation of the results that can be achieved?
I wouldn't say so. I think most people have a good awareness of the limitation of surgery, and people know that the results are not guaranteed and there is variability of it. I would say don't compare yourself to what you hear on social media. Like if you come to my consultation and you say, I want a voice like her, or I want a voice like him in a trans men, I'm not going to be able to provide that as period. Like you can't, yeah, you will have your voice, but in a different pitch, in a higher pitch. So you can't compare yourself and expect a voice that sounds like somebody you heard because their results are great. So that's essential. But I don't think people have really unrealistic expectation. Not the majority, maybe a minority, maybe, but no.
And what do you say to patients who they want to shop around? Now, the techniques you've developed and involved on the Wendler glottoplasty are the gold standard, is how they're described. But what about if they go to a surgeon who says, wait, no, I do this other thing and it's so much better. You've got to listen to me. How do you approach that?
I would say listen to what others say. Like I don't claim my opinion is better than anybody else. I think there is a general consensus between all of the surgeons that do this work, and there aren't many of us in the world. Like in Europe, you will have 5 or 6 people that do the surgery. And worldwide, like within our International Association of Trans Voice Surgeon, where every country there will be one or two people, and then we discuss techniques, we discuss what we all do, and the vast majority of us agree that Wendler glottoplasty is the best first line intervention. We all have our own modification, and maybe somebody think their way of putting the suture is better than mine, or mine is better than theirs. I do laser release, some people don't. So there are these tweaks, and they have pros and cons like everything else. But I think there is a general consensus that Wendler's glottoplasty is the best first-line intervention. Apart from that, you will have like two realistic options. So you will have the vocal fold muscle reduction, which I do as well. I normally would do that as a second line. I can do it as a first line if that's the person wish, but the pitch increase is really limited compared to what you can achieve with a glottoplasty. So this we will do in like special cases. Apart from that, the only real option you have is the feminization laryngoplasty, which is done by a single surgeon, James Thomas, in Portland, in America. And like worldwide, he's the only one. James is a great guy, and he's been doing the surgery with fantastic results. But I think it's fantastic in his hands. He's been doing it for the last 15, 20 years. The surgery is really invasive compared to what a glottoplasty can achieve. Like we do endoscopic keyhole surgery, while the other one is like opening a larynx and reconstructing it from scratch, basically. So I think it's a lot safer, and the results are comparable between the two in my mind.
Just to follow up then on that, one of the things that we've noticed is there's quite a lot of scratchiness during the recovery period that can last for a year, maybe more. Is that typical with your technique, or is that a characteristic of some other one?
Some people their voice takes some time to settle, and it's variable. I would say voice largely settled by 3 months. And I think I have people, when they come back at 4 weeks to see me, some people voices have completely recovered, mostly will have some hoarseness left, some strain at that 4 weeks. I think the voice continued to change up to that 3 month, when the vast majority will settle within 3 months. But wound healing after surgery, and that applies to any surgical intervention, scar remodeling and wound healing, it takes 12 to 18 months to happen. So there is still subtle changes that happen after that 3 month period, but it is really subtle. I think where you are at 3 months is pretty much where you're going to be. And if the voice is really poor at that point, then something needs to be addressed. Mostly they need a lot of more therapy, and maybe different focus of the therapy to try to release some of the muscle strain and muscle tension.
So do you think if someone has, as we said, like a scratchy voice, that's potentially more down to the fact they haven't done their training rather than the surgery?
No, I wouldn't say that. I think it's possibly a combination. It depends what you can. One of the things we see in our surgery is like granuloma, which is granulation tissue, which applies to any surgical intervention. But when the vocal cord in particular, a couple of millimeter granuloma can make a difference. So that can affect voice recovery. It can add weight. So that's potential thing. That's nothing to do with the therapy or the training. So this is purely sequelae of surgery. Sometimes you will have, people when they heal, they don't heal with a sharp angle, they heal with a slightly rounded tip, so they have more breathy voice. Again, this is not therapy, but therapy can help compensate for these and can help address or iron some of these voice difficulty. While in others, it is because they developed vocal pattern that involve a lot of muscle tension. And either because haven't done enough therapy, or because it's difficult transition when the vocal cord have been adjusted surgically that much. So, and that's when therapy comes, because it help that recovery and help using. When we get poor vocal pattern, it becomes ingrained. And once you have an ingrained vocal pattern, it's a lot more difficult to get rid of it rather than not develop it at the beginning. Like what can be sorted with 2 sessions after surgery will require 6 months of therapy after to try to reverse this ingrained vocal pattern.
Yeah, so that was the consult. Can we move on to talk about the actual surgery itself? And what do you think a patient should do to prepare for surgery? I.e., do they need to stop hormones? I know that varies from surgeon to surgeon, but what's your opinion on that?
Not for my surgery. Our surgery is day case procedure. It's a small surgery. It's a keyhole surgery, minimally invasive. It doesn't reduce mobility. So people come in, have the surgery. 2 hours later, they will be on their way. So I do not ask
Few
for
hours.
people to stop hormone treatment. Not for my operation. I fully understand for like major surgery that affect person mobility. Then that's important to reduce the risk of a DVT or like a blood clots in the legs and go into the lungs. So you don't need to do that. I think the stuff that you need to do is you've done your session of therapy, you prepared yourself, you looked into how you're going to communicate after surgery, you thought about telling family and friends, like I can't talk, like prepared the environment around you to be accommodating, arranged that you have what help you need. And then clinically, if you smoke, you need to stop smoking, and that's for sure. And I would say you need to stop smoking at least a couple of weeks in advance, ideally more, because once you stop smoking, you start coughing, and the last thing you want is to cough straight after surgery. So you need to
Yeah,
stop smoking
absolutely.
well in advance, get that cough period out of the way, and then you're ready. And that's pretty much about it, really. If you have any specific medical condition, then we need to prepare for that. Like if there is
Hmm.
other health concern, we need to address that, change medication accordingly. But otherwise, not really, not a lot.
So, so how do I never really put any thought to this, but how do people mainly communicate after the surgery? Like, I guess, and they used to walk around with a notebook, but now maybe they have an app.
Yeah, so there is type to voice app, so you can download these and you can type, and the app will generate words, and they're quite good. A lot of text messaging, like as you know, in modern life, we text more than we speak nowadays. Most people communication is on WhatsApp, so a lot I use WhatsApp a lot more for texting than I speak on my phone, and I think that does apply. And some people like it the old-fashioned way, so pen and paper and write what they want.
So now, pardon me, got a frog in my throat.
You need a good throat doctor to take a look.
If I'm transmasc and I want to get a masculization surgery, how long should I wait to see what effects tea will have first?
I would say, as an absolute minimum, 6 months. A lot of the changes happen within the first 3 months, but it can change up to six. And ideally, my genuine advice will be wait for a year. Don't rush this, because while Wendler's glottoplasty is a very good operation, it gives very good voice outcomes. Pitch deepening surgery, it can change the pitch considerably, but it has some downside to it in terms of like projection and roughness of the voice. So the risks associated with it are higher. So I would definitely not rush someone into it. And we know that testosterone works in almost 100% of cases, maybe not to enough to get the voice down to male range, but at least in 70%, it can get to male range just with testosterone. So don't rush. Definitely don't rush for this one.
You mentioned pitch there. Could you elaborate on how you measure success post-surgery, both in terms of pitch and patient satisfaction?
Yeah, so uh, we measure it. So we measure the pitch before and we measure the pitch after, and we compare the two, and then we get demonstrable pitch increase. What is a successful outcome is not a number really. It's like how person perceives their voice and how happy or unhappy they are with their voice. In
Yeah.
most research you look at, you will have that cutoff around 165. And the 165 is based on research. So if you give a range of voices to blinded assessor, so somebody does not know who's speaking, they just hearing voices and they choosing male, female based on the voice. Once the voice go around over that 160, 165, most people will start calling that as a female voice. But that doesn't mean that it is right for you or right for them or right for the other person. Each person have different voice goals that they would like to achieve. And we try to work to the individual voice goals rather than 165, you're good, off you go. What 165 is great for someone, for somebody else, is their starting pitch and they're coming for surgery because they're really not happy. So we try to see what's the person own voice goals and see if it is realistic and can we achieve them. So that's one in terms of pitch. In terms of patient satisfaction, we use a validated prompts, or like what in short prompts, so it's patient reported outcome measures. And we use two in particular. So we have something called VHI 10, which is the 10 question voice handicap index. And that looks into general voice related quality of life, as in how much a voice impacting a person's quality of life. And this is a general voice. So this applies to hoarseness, applies to, it has like something that directly related to voice, but it could, it relates to happiness, it relates to work, it relates to confidence, all of that. So this is general voice difficulty. So that's one. The other questionnaire we use is called the TWVQ, which is Transwoman Voice Questionnaire, which is specifically designed, is based, initially was based on VHI 30 and then got expanded and made particularly to address the areas that trans women face in particular, social participation, discrimination, speaking in a loud environment, all of that aspect, as well as that specific voice. So we do those two, and we measure these before surgery and 4 months after surgery, and we can compare the outcome and the difference between the two.
Do you ever have a patient get freaked out by their new voice because they don't sound like themselves anymore, or they don't expect it to sound like they do?
It's our brains are amazing how they adapt. We adapt really quickly. We forget what our old voice was. Like it is your voice, and suddenly it's your voice, and your brain have great ability to to process that information and to ingrain that voice in your day-to-day life. And then even that voice, you start thinking in that voice. You don't think with your old voice. You start thinking, like that's internal monologue that we have. That internal monologue is in the new voice, and I find this one fascinating as well.
Yeah, I never even thought about that.
Yeah.
Yeah. What other quality of life improvements do you think might be measurable experientially? Day-to-day interactions, that sort of thing.
Right. A great deal. Like I always say this. When I wake up in the morning, I open my mouth and I speak. And the only thing I need to think about is what I say. Yeah. So imagine you need to do that, but at the same time, you need to worry about how you sound, how you're going to hold your larynx, how you are, how you feel, what's dysphoria you're getting from your voice, how people are perceiving you around, and how people are looking at you. Are they going to misgender me? Are they going to distrust me? So it's a huge impact on a person's quality of life. And it is just the simple things, like I had somebody to come and say, it's for the first time in my life, I go to a coffee shop and I order myself rather than asking my boyfriend to order for me. These are like simple things that we take for granted as a cis person, and it's a daily struggle for a trans person. So it's a huge impact, and it's the small things that make all the difference. It's just like when you start talking and somebody give you that second look, you know that feeling.
Yeah, we know that you're preaching to the choir.
I know I've never ever experienced that feeling, and I can't imagine how that, but that disappears. Like it's these small things that make a huge difference.
Yeah, it took some bravery from both of us to actually do a podcast.
Yes, yeah. No, I really appreciate that.
And we neither of us like to answer the phone. It's please text, because we get by just fine in the outer world until we speak.
Yeah.
I
want to ask you, what inspired you to adopt modified Wendler's glottoplasty as your preferred technique, and how has it evolved in your practice?
We had the old operation that we all used to do was the cricothyroid approximation, and at some point that was the only thing that was available. And it was developed in the late 80s by Professor Ishiki in Japan, and it became the standard for pitch elevation surgery, gender affirming vocal surgery. And we did it. I did cricothyroid approximation as a trainee when I was still learning, when I was doing my higher surgical training. And that's how I started how I got into gender affirming vocal care. early on in my career. But the outcomes of crack throat approximation are really not great. When we had no other options, it was that we had no other option. It's either that or nothing. But then when I got exposed and I learned about Windler's glottoplasty and the outcomes that people were achieving, I thought that that's definitely the direction we should go to. And I started, you know, learning from other colleagues around the world who start doing the operation because to a long period of time, it was only done in where it was the birthplace of the operation, which is in Charité in Berlin, where Professor Windler used to work, and a couple of other places, South Korea and Yeson Clinic and Helsinki, which was a trainee. The laryngologist there was Windler's trainee. But over the last 5 to 7 years, there has been a wide dissemination of this technique. People start picking it up. It was Professor Mark Remarkle from Belgium, now in Luxembourg, who picked it up first and start popularizing it and publishing papers on it. And when I started reading these papers, the outcomes were far superior to what we can achieve with crack third approximation. And that's pretty much what moved me in that direction. And then I started to look at my results. And one of the things I really do, and I wish every surgeon do, is I keep really good record of my results. I keep a record of every single case, and every case you learn from. You learn, you see what worked, you see what didn't work, you see what I did there. How can I refine that? How can I get this process that extra 1% here, extra 1% here to continuously, it's a continuous learning process. And you get that when you look into your results. It's great when you say, oh, my patients are all happy. Yes, the majority are happy. But are you happy? And can you prove that scientifically? Are you looking at it, like really looking at it? Are you looking at your outcome? Are you looking at your technique? Are you being honest with yourself when you say, oh, my patient never gets a complication? There is no surgeon in the world gets zero complication. So it is that strive to always do better, always learn, and always move it to a step forward for the benefit of my patients.
Mm.
Sorry, I something I feel really strongly about. So
That's okay. That's a good answer.
yeah.
Okay, now I've got two questions for you. Firstly, if I decide to call you now and say, please, I need this surgery, which I do, when could you schedule me in?
Oh, well, you need to come and see me for a consultation. We need to talk through it. We need to make sure that what I can offer align with what your needs, etc., and go through that process and make sure that this is the right thing for you. I do a cool down period, so it will be. I normally say like 2 to 3 weeks cool down period. In real life, is like 2.5 months, pretty much. Wait from the consultation time to surgery time.
And how long is the wait for the consultation?
Consultation are quick. Within a week or two, you can come and see me. I always have a space for a consultation, so it's not a long wait for the consultation. So possibly whole process from you first contacting my secretary to come for a consultation, it will be like couple of weeks time, and then if you really want to go ahead with the surgery, is possibly 2.5 months after that. This is my current waiting list.
And what if I'm also what if I also want to have a tracheal shave? Should I try and get that done before the surgery? Given there are some risks, aren't there? Complications.
Well, yes, there is. I think it doesn't matter which order or if you combine them, as long as the tracheal shave is done properly. There is risk with tracheal shave, which is mostly risk related to over resection, removing too much of the cartilage, because that's where the vocal cord attached. So if you have a string and then you snapped it from one end and it became loose, like there you can never tighten it back again. There is no surgery that can repair a complication from tracheal shave or like Adam's apple reduction. So if you are gonna do it, I would say mostly it needs to be done safely, and by done safely is done by an experienced surgeon. I would say, and I'm biased here, I would say go to an ear, nose, and throat surgeon, go to a voice specialist, not a cosmetic specialist, to do the surgery for you. Somebody who really understands the physiology of the voice and the mechanisms of the voice. But that doesn't mean like our plastic and cosmetic surgery colleague do not do a great job. I'm sure they do with the vast majority, but it's an added layer of understanding of how much you do will impact somebody's voice, is essential. But if it's done properly without over resection of the cartilage and no complication, it doesn't matter which order you do it or combined at the same time.
I have a question that we haven't even planned for, but it's about the rainbow passage that you and the vocal coaches use. When was that first used? I love it. When was that first used?
Oh, I can't tell you from the top of my head. It's like sometime in the 1960s. This was um devised. So, do you know why the Rainbow Passage, or what's special about the Rainbow Passage?
No, tell us.
Within the first four lines of the Rainbow Passage, you have every phoneme of the English language, every letter and every consonant in every variation of pronunciation is within the first four lines of the Rainbow Passage.
I love that.
And that's why. So it's a standardized text that look into the full spectrum of voices that we produce speaking English.
Do you know it? Have you listened to it so much now you know it by heart?
Of course, I know it by heart. When the sunlight strike raindrops in the air, they act like a prism and form a rainbow.
Oh, very good.
Well, thank you so much. That's the end of our questions. You've covered it all, I think, unless there's something you'd like to add.
I think we covered everything. We covered the whole process. We covered pros and cons. There are, I would say, one thing we haven't spoken about is, are there downside to the surgery? And there are potential risk and complication, and thankfully they are very rare in this surgery, in terms of surgical complication. However, there are some vocal trade-offs that one need to be aware of. It's mostly there is a reduction of volume and projection after the surgery, and that's something that will happen. It's happened to absolutely everyone. The degree of that varies, and it impacts the person. It depends on how they use your voice, the environment they work in mostly, like how noisy is the environment they work with. So if somebody works in retail or customer facing roles, or like in an office based job, online meeting, face to face meeting, it's normally is absolutely fine. If you are a DJ in a nightclub, then it is a major issue because you can't get yourself heard over background music. So that's the one thing. And it gets better with time. Therapy can help because it can devise alternative way of how to project your voice that does not rely on sound pressure, which vocal cords after modification can do. But apart from that, it's an operation with low complication rate and high patient satisfaction.
I remember from your presentation as well mentioning that it's the lower end of your range that goes up, but the higher end does not go up correspondingly. So you end up with a reduced frequency range.
Yes, you do. So it's variable, and if you look into research result, it's variable between paper. But I think in the majority of cases, you will have a reduction of the range. So if that's the vocal range, lowest note you can hit, highest note you can hit. What tend to happen is the bottom of the range goes up. So you eliminate these deep notes that you don't want in your voice. The pitch goes up, but the top doesn't go. So effectively, the range is narrow, but in a good way, if I may. So if you're a professional singer, it's a major issue. But for the majority of people, is getting rid of the deep notes is a great outcome.
I'm a professional not singer. I get paid to not sing, so that's fine by me.
You definitely can do you no harm then.
Whereas I'm not a very good singer, but I do love to sing, and also I voice a lot of characters for our daughter, and work in a noisy environment, so I'm not a good candidate for it at all.
You need to go with the right balance. You need to balance the impact on your quality of life of both. So it's a trade-off. Is that trade-off worth it, or is not worth it for you, for your need, for your vocal need? And then come to a conclusion and a decision based on that.
Oh, well, that might lead us to a good final question then, which is, I guess these are the sorts of discussions you have during the consultation, and setting of expectations and outcomes, etc., and the balance. So, how many patients do you see who don't go ahead because they're concerned about the outcome, impacting their life in some poor way?
Small minority, I would have to say. I think most people would have done their research beforehand, and most people are aware of these. And they came to a conclusion that is something they would accept before they come and see me. But in small percentage, when you actually learn what it is, and how much it impact you, few small percentage would either pause and decide not to go ahead or look at alternatives. So if you think like loss of projection is unacceptable or loss of volume is unacceptable, then we can look into doing the muscle reduction as an alternative. It's not going to give us the same pitch increase, but it carry less risk. And that's how we can individualize it for person to person.
So even if you're worried, come in for a consult anyway, because there may be a solution.
Yes, absolutely. And then and when you hear that, oh, you can't get your voice up, it's a scary thought. But when you come and you see, just have a chat with me about how it's going to impact your day-to-day life, what's going to happen in a month time, like, can I use my voice in this capacity or in this capacity? And where am I going to get struggle? You might find that it is, yes, it is, a trade-off that you're happy with, or you might think that's, oh, absolutely not. This is not something I want to sacrifice. And then absolutely, by all means, we have therapy to go for, and we have alternative surgical intervention. And there is pros and cons to every approach.
Well, Doctor, thank you for that absolutely fascinating journey into vocals, gender-affirming surgery. We're both full of admiration for what you do and the lives that you make better. We've heard these types of surgeries defined or described as life-completing surgeries. And we're so glad you're part of that and you bring that to so many people. Thank you for joining us.
Thank you very much for having me. Thank you very much. And it's truly humbling when you make a small contribution that change somebody's life or make their life better in one way. It's something filled my heart with happiness, and I genuinely say that.
Thank you so much.
Thank you very much. Thank you.
Wow, that was a great interview.
It really was.
I enjoyed it so much.
You did? Yeah, me too.
Yeah. Anything to add?
No. There's a lot to...
I think we've said enough already.
We have. Okay, let's wrap this up.
All right then.
All right. Thank you so much, listeners, for tuning in and for being part of our community. And if you want to connect with us further, visit our website at redandfreckles.com, where we'll keep you up to date on all things red and all things freckles and everything in between.
You can also follow us on Blue Sky, Threads, Instagram and Facebook, but not Twitter anymore, because the account's still there, but we're not using it. On all of the other social media, we use the handle @2damptrans. And on all the platforms, you can DM us if you have any questions or topics you'd like us to discuss.
And please don't forget to subscribe and rate us on Spotify, Apple, YouTube, or wherever you listen to podcasts. We're on all those popular platforms.
And even some of the unpopular ones, Twitter.
We do appreciate your feedback and support.
So until next time, remember you are valid.
You are beautiful.
And you are transcending boundaries.